My task is to speak with you about, is door-to-balloon the wrong measurement for STEMI care? And if we go back to the 2013 practice guidelines, I think this emphasizes some of the problems that we've had with acute MI care in the United States. Reperfusion therapy schematically can be divided into patients that undergo acute intervention or patients that present at hospitals where acute intervention is not an option, and those patients are required to be transferred to a PCI-capable facility. So patients that go to an initially PCI-capable facility are sent to the cath lab with the plan of having a door-to-balloon time of less than 90 minutes, which has been extended to 120 minutes. This includes a diagnostic angiogram, and based on that diagnostic angiogram, even for patients that have acute myocardial infarction, they can be stratified to medical therapy alone, PCI, or CABG. Now, the door-to-balloon time basically is the first medical contact to the first device. In the catheterization laboratory, once we put that first device into the patient, then we notify the technicians that we've achieved our door-to-balloon time. In 2015, these recommendations were updated. And part of the reason for updating these recommendations is based on practices in the United States. So when we look at these practice guidelines, this is primarily aimed at the United States, but the results or the implications can be applicable to other areas. In 2015, one of the recommendations had to do with taking care or intervening on the non-infarct vessel. Traditionally, we had been taught that you only intervene on the vessel that's the acute infarct vessel, and the non-infarct vessels are not intervened unless the patient is in cardiogenic shock. That was updated to the recommendation that it may be feasible in certain patients to address vessels other than the infarct-related vessel. Another recommendation had to do with thrombus. We had a very zealous period of time where we intervened on thrombus by doing aspiration in patients with acute myocardial infarction. And this was basically all comers. And what the more recent trials have demonstrated is that maybe aspiration is not the best treatment strategy. In fact, we may be harming patients by doing aspiration in all comers, and so that the recommendation for thrombus aspiration was actually downgraded with this most recent recommendation. Now, if this angiogram would play, then what this angiogram would demonstrate to you is a patient with a very large thrombus burden visible in the proximal right coronary artery. So certainly this subset of patients with visible thrombus is different from those patients that don't have visible thrombus, and perhaps may be the reason that some of the more recent trials haven't demonstrated the same results that we saw in some of the older trials. So the use of thromboaspiration would still be left to the operator's discretion, depending on what he sees in the angiography suite at the time of the index procedure. Similarly, this is a patient of a case I was asked to review that had an acute anterior myocardial infarction and underwent PCI of the LAD, which was successful. Then the operator decided that, well, there's a proximal LAD and distal left main stenosis, so attempted to stent the osteo-LAD, the left main, then got very creative and did bifurcation stenting of the LAD and left main. Was about to take the patient off the table when the patient suffered acute thrombosis, ventricular fibrillation. Despite ACLS, the patient died on the table. So clearly, this is a patient that perhaps with just index vessel intervention may have survived this acute insult and could have been completely revascularized at a later date. So although the recommendations are more liberal than what they had been in the past, I think we as operators still have to use our clinical judgment when we address these patients. Now, one of the interesting facts is to remember that the pre-hospital mortalities are the patients that die before they get to the hospital, or the patients that arrive dead, aren't included in any of these observational studies. So we really have a skewed population of patients that we look at when we look at acute myocardial infarction or STEMI survival, because we're looking at the ones that survived long enough to get to the hospital and survived long enough to get to the catheterization laboratory. This is important when we compare this to what happens with the inpatient acute myocardial infarctions, which I'll address in just a minute. Now, mortality with STEMI, if we delay treatment, whether that's thrombolytic or interventional, then we know that we have worse outcomes. Early detection and intervention may improve outcomes, but it's interesting that when you look at the mean time from symptom onset to hospital arrival, that number really hasn't changed in the past decade. And in fact, it's about 2 to almost 3 hours. And even for patients that have a second or a third myocardial infarction, the time from them making it to the hospital really hasn't changed. So either we've done a poor job of educating patients, or patients have done a poor job of understanding the pathophysiology of their disease process, because they still don't come to the hospital any earlier, even though they've already had a myocardial infarction in the past. This led to some investigations, and I put this in just as food for thought, because this is using a right ventricular lead to detect early ST segment changes. So before patients realize that they're having a myocardial infarction, this EKG warns them that they're having a myocardial infarction so that they can get to the hospital faster. Now, I'm not recommending this, but perhaps in the future all of us will have a chip or a lead implanted so that when we have our first myocardial infarction, we'll get to the hospital in 19 minutes instead of 2 hours, like patients that usually don't come to the hospital any sooner. And we do know that the mortality is a direct function of ischemic time. So the longer a patient is ischemic, the more likely they are to have a mortal event. So door-to-balloon time was developed really for patients that have their heart attacks outside of the hospital. It doesn't address patients that have a non-ACS admission to the hospital or get admitted and have a MI while they're in the hospital. And in fact, if you look at that patient population that has myocardial infarction in the hospital, these are different because they tend to be older, more likely to be females, have more comorbidities. It takes longer for them to get an EKG and that EKG to be interpreted to get them to the catheterization laboratory. And their time to their first device is extended compared to the patients that present outside of the hospital. So although we may be improving what we do as far as door-to-balloon time for patients that come outside of the hospital, all of those patients that are in the hospital have a much worse prognosis or much worse outcome than the patients that we see coming in off the street. Another interesting phenomenon is that if you look at this slide, and it's rather busy, but it divides it into total patient population and then some high-risk subsets of patients. The blue line is the mortality, and the other line is the door-to-balloon time. And what we see is across the board, door-to-balloon time has decreased. We also see across the board, mortality has stayed pretty much flat. And we also see that the numbers of patients in these groups is actually increasing. So increasing patients, mortality staying stable, door-to-balloon time is dropping. We're missing something. So there's something else that's operative in this formula that we're not aware of. And so when we look at this, we can determine that the door-to-balloon times have significantly improved, but mortalities haven't really changed. And it may be a factor of something other than just the door-to-balloon time. Door-to-balloon time is just a part of what we would consider the ischemic time, or from the onset of the ischemia till the time that patient gets treated, with a balloon or with a device. And it makes sense because when we remember that other slide that I showed you, if door-to-balloon time was the only factor and you saw significant decreases in door-to-balloon time, then it would have made sense that the mortality would have responded, but it did not. So that door-to-balloon time, although it's a part of the total puzzle for ischemia and mortality in these patients, is not the only operative factor. So it's really infarct size that strongly affects mortality, and that's correlated with the total ischemic time. So it correlates more with the total ischemic time and less with the door-to-balloon time. So the total ischemic time is really the onset of symptoms to reperfusion. And this is just an estimate because onset of symptoms, maybe the patient doesn't have symptoms, maybe the patient has a period of time where they're ischemic before their symptoms develop, And so determining what the actual total ischemic time is still a puzzle to us. I think in conclusion, we should be focusing on reducing sort of the total ischemic time. The door-to-balloon time, we still need to focus on reducing it. And the reason for that is that's an easy target. So from the time a patient gets into the hospital, we can facilitate getting the patient to the laboratory, revascularizing the patient faster and more efficiently. And that's a target that all of us can address in our institutions. The outside of the hospital factors of the total ischemic time is more of a problem, and I think it's food for thought for us to come up with systems in our communities so that we can address this patient population in a better or more thorough type of procedure. Thank you very much.